My name is Hannah Kienzler. I'm Professor of Global Health in the Department of Global Health and Social Medicine and co-director with Professor Craig Morgan of the Centre for Society and Mental Health at King's. It's a huge privilege to welcome you and have you all here from different locations and walks of life to hear about the research the Centre has produced as a collective under the amazing leadership of Dr. Dr. Bemme and Dr. Dominique Behag. The special issue is brought us all together as a centre, and is also reflective of the centre as a whole, as we are generating and utilizing interdisciplinary research and partnership with those affected community organizations and different stakeholders to shift public debate about mental health away from the focus of individualized interventions towards social practices and policies to promote and sustain good mental health in community. Questioning and interrogating both the social and mental health are, of course, central to this. And we are exploring this messy space that unfolds where the social and mental health interrelate and become somewhat indistinguishable from one another. As the special issue powerfully shows, there's no way of exploring and understanding that messy space in between, considering our diverse knowledge communities in the centre and beyond. The special issue has started this important and also radical conversation that strives to struggles with that tension between heterogeneity, allowing for different voices that don't all align, and inclusivity that creates a somewhat a common ground. So this will be a conversation. This is the start of a conversation, and which will be continued over the long term in the new social theory corner of the journal, about which we will hear more about later. But instead of hearing from me, we have an amazing lineup of speakers, and it is my great honor to introduce our keynote speaker, Harry Sehwell. Harry has supported and shaped the progress of the Centre from the very beginning as a member of our scientific advisory board. He's founder and director of HS Consultancy and is a former executive director of health and social care in the NHS in the UK. He's a writer, a powerful speaker, and a tireless organizer and campaigner in his specialist areas of social justice, equalities and ethnicity, race and culture in mental health. It's a great privilege to be able to learn from you, Harry, so the floor is yours. Thank you.
Good evening and good night, good afternoon, wherever you are online. Welcome to the space. Thank you for that very kind introduction, and thank you for the invitation. And it's a real honor to be in this space and in this role this evening. Thanks to all of you. So I just wanted to start by saying something about me, just to kind of put into context why the social matters so much. I'm someone who grew up in Jamaica in a very Christian society and in a kind of church-based community where relationship and community was real in the way in which we operated. And I'm a social worker by background. So my interaction with the world is very rooted and grounded in a social orientation. And I kind of think it's really important just to kind of name that for me. This isn't just an area of study or an area of interest, but it kind of is in my cells, really. So what I kind of just wanted to cover, I wouldn't move too far from the mic, but I wanted to, there's something under my feet. So what I wanted to cover in this short while was just my reflections on this special edition. And then to kind of pull out some key themes. One is around how in the journal we see the visibilizing of the researcher in a way that isn't typical. Also, the way in which social is given space to be political in a way that we often don't see. And then the way in which the content of the journal rightly disrupts some of the orthodoxies, and then to kind of pull it all together. So just kind of reflect on this being an act of resistance, just pulling together so many radical articles and schools of thought is an act of resistance against the dominance of, say, neuroscience in the field in which we operate. So yeah, I just want to kind of give you some of my thoughts on it. Firstly, I think it's absolutely fantastic and well done, everyone who's contributed, and well done for the team for even conceptualizing it and putting it together. It is a fantastically rich collection of articles. If you've not seen it, I'd really encourage you to access it and immerse yourself. And like me, just keep going back and thinking, and I've read this one before, but you know, where's that thread? And what's the thread between them? So yeah, I'd really encourage you to do that. What's also powerful in the collection of articles is the offering of conceptualizations, language that helps people to think, but also to communicate about some of the essentials of the social within the context of mental health. And that's really important. One of the things that's kind of really striking in our social world is that some words, some ideas start off being marginal. And the more we use them, not just as individuals, but in relation to each other, and use the privileges that exist with being part of the establishment to use these words and concepts, it becomes embedded in our society and they become normalized in the good sense of that. Because it no longer will be treated as things which are marginal or peripheral, but hopefully becomes part of the mainstay of the way in which we can think about mental health. And that social bit in there is really, really important. What's also powerful is the collection of diverse voices. And this is kind of one of the key themes in it. What social in this way is about is living with multiplicity. The fact that sometimes in our world, we're trying to arrive at an end point where we all agree that the evidence supports a particular thing. And what this collection of articles does, it kind of presents different doors into the social, whether it's looking at the inside of mental health as a system and trying to kind of understand that, or looking at community, or looking specifically at the role of the researcher. There are kind of different gateways, different doors into it, and kind of holding that possibility that social isn't just one thing is really powerfully achieved in this collection of articles. But of course, there is a tension still, which is when I looked at the articles and I was kind of thinking, wow, these are high quality. And then immediately had to question myself as to upon what basis am I judging these as being high quality? Because of course, everything is derivative. And you know, my learning will be on the foundations of ideas that I'm now critiquing. And I'm thinking, okay, right, so these are well written, they present ideas in a kind of linear fashion, all the things that we might consider to be some of the hallmarks of, you know, solid academic writing, you know, the research-based citations, it kind of looks really, really good. And is this really the defining aspect of social if what we're trying to do is to move towards what I kind of talk about later on around radical imagination? Are there different ways? What's been excluded from the possibility of learning when what we've got is a special issue? You know, for example, where's the space for, I don't know, theatre of the oppressed as a way of examining how people experience the world and the possibilities that are out there? So though I champion it, and I kind of think it's an absolutely fantastic piece of work, I also am keen for us collectively to begin to think about what are the other possibilities, the different ways of knowing, which is kind of really important here. So I kind of wanted to move into the bit where I talk about visibilizing the researcher, and that particular paper by Hissan is kind of really great. I've got that quote there just to kind of really capture some of the essence of it. A first person voice that makes the author visible in the process, which in many ways is the antithesis of what we're encouraged to do in academia. But not only does the author, the researcher, do that, there's also positionality central to it. And this is kind of really important when we engage in work, research, and work around in the social field, to recognize that traditionally, we both as academics, but also as clinicians, act as if we are invisible in the process. And, you know, for those of you who are immersed in feminist writing, you all know that kind of one of the hallmarks is to kind of, you know, critique the idea of the neutrality of many of the processes that we kind of present as objective. Because once you introduce a human being or a collection of human beings into a process, by definition, it's going to be situated, as we've said, in terms of the context and time, but also it's going to be affected by the presence of the individual. So it's really great. I think it's a valuable lesson as we go through and see a solid piece of writing where you've got the person identifying that they are part of the process. If you're unfamiliar with the language of positionality, it's really recognizing that the aspects of our identity that inform our work are there and they're present. And there is some benefit in acknowledging to ourselves, but acknowledging to others that it's there. For example, many of us in this work, not all of us, will come from middle-class backgrounds, and that will inform the way in which we see the world, the way in which we relate to other people, what we consider to be valuable in the appropriate way to write, to behave, to interact. And often that's invisible to us, particularly when we're operating in a field where many of our peers are also from middle-class backgrounds. That just becomes invisible. So the benefit of positionality, of beginning to name and identify those things, it brings to front of mind that this is a part of me that is present that will affect the process. And in research, you'll know that you know, people with lived experience will be involved in research because we know that we get different stories from other people with lived experience if they're speaking to someone who they feel there is some kind of common understanding with, and so forth. And that's why positionality is kind of really important. And also, as I say, the kind of challenge around the ideas of objectivity. So I'll kind of move on to the other point I made around politicizing the social. And this is kind of really important because the fields in which we operate, often with public sector funding or with the roles are within public sector bodies, kind of requires us to operate as if we're politically neutral. And what the collection of papers do is to make it absolutely clear that once you begin to examine things like social injustice, you are by definition being political. And there's a way of thinking about this, that we're not talking about party politics, but what we're looking at is the fact that they are political decisions that mean that some groups will be marginalized or some groups will face disadvantage. And by definition, once we start to talk about social justice, it is going to be political. And I kind of think the papers really embrace that. And the language that we see of like decolonizing or, you know, the critique of extractivist capitalism or naming things like settler colonialism, naming patriarchy and the function of feminism in these spaces, they're real powerful ways of normalizing the idea that the social and mental health is acknowledging that this is a political field. The reason why it's really important also is because if you think about the way in which people will often in campaigns talk about mental health, the analogy of we don't discriminate against people with broken legs, so why discriminate against people with a broken mind? The presupposition being that it's apolitical, it's just that someone's accidentally broken their mind, and you know, let's just kind of make sure we don't discriminate against them. Whereas often what we see based on research evidence is that there is a disproportionate number of people who face social disadvantage who are using our services. That connection is well established to the point that some of those links are causal, if you kind of look at the experience of childhood sexual abuse, that we now are at a point where we can kind of say it isn't just a correlation, but there's a causal relationship in terms of hearing voices in particular. And for us to then be silent on the politics of that is in many ways quite abhorrent. So we kind of use terms that, for example, violence against women and girls as an example, where just that doesn't say where the violence is coming from. And that's kind of what's really important, is that we're able to be political enough to say there are gender patterns in where the violence comes from. We all kind of know what they are. What's also interesting in the collection of articles is acknowledging that the language of social determinants is kind of passive. And I really like that Latin American social medicine idea of naming the process. Because once you name the process, it then begs the question as who are the actors behind that process, and it engenders accountability. So as you go through the articles, you see a lot more insistence on those who are accountable for social injustice really being held to account. And for me, it links into the work of people like Antonio Gramsci, who kind of, for those of you who are unfamiliar, most of you probably are, the kind of idea of the hegemony and, the fact that what we consider to be political is defined by the elite and those people with power. And I kind of think that really strikes me. So even as I talk about the fact that this special issue begins to bring the politics, the political idea back into mental health, I'm thinking, well, who's defining what we consider to be political and what we don't? So if we're kind of talking about the role of the pharmaceutical industry, and we're just kind of talking about it purely in terms of the function of what is prescribed, that's kind of seen as apolitical, quite a reasonable, neutral thing. But once you start to kind of talk about dealing with those systems of oppression and the actors who cause injustice, that will be interpreted as being political. And it's really important for us to be clear as to who's defining what is political and what is apolitical. I'll just pause for a minute and tell you an anecdote from my past that kind of really always comes back to me. I remember when I was studying to be what was then an ASW, the AMHP, the Approved Mental Health Professionals role, and I was on a placement in Hammersmith in London, and one of the assistant directors came to the location where I was, and I was young, forgive me, right? And he came to that particular site on a push bike. He cycled from the other part of town to the venue. And I remember saying to one of my colleagues, how come like the authority allows him in his role to arrive on a bicycle? Does it not look unprofessional? And then now I kind of think our decision to fly around the world or to drive SUVs, they're real big political decisions. That's the point I was getting to, that we might think it's an act of individual choice, but even those decisions are super political because we're making the decision in that moment to prioritize our ease of navigation or our desire to see 3 countries in a year over the impact that we know it has on the climate crisis and largely on Indigenous people in the global south. So the journal is really good at naming things like that. And then we get the disruption of the orthodoxy. And this is kind of very hard because we're writing about a field where there's a common language and a common understanding of what it is we're talking about when we say mental health. And what's kind of really good in the collection of articles is paying attention to this epistemic injustice, the knowledges that we value and the ways of knowing that we value. And that is named. And it's kind of really clear that in terms of the work that I do, that many people don't really appreciate that the educational system and the way in which our society operates just normalizes and accepts that, you know, there is this kind of hierarchy of evidence, and there are ways of conducting research that we all kind of sign up to as the gold standard, and we operate within that. And the challenge for us, particularly for those of us who are educators working with students who need to kind of achieve, is that we have to use those tools and teach them these things that we are at the same time criticizing. And I describe it as me standing on foundations, which I am at the same time putting a sledgehammer to. That's what it feels like, because, you know, everything is derivative, and the confidence and the knowledge that I've got now is based on ideas and constructs that I've embraced and have internalized, that I place value on in one part of me, and in another I also critique. And also, in the collection of articles, you'll see the critique of the diagnostic process in the DSM-5. There's so much material out there that really acknowledges that what we're looking at, as I said before, is something that is social. Despite the way in which we'll kind of think it's a scientific document, it reflects the time. That's why it changes with the time. That's why up until 1975, being gay or being lesbian would have warranted your inclusion within that criteria, and then it changes because, of course, these aren't conditions that we can go, okay, you have this thing and it's real, and we're going to do a biological test for it. That we're reflecting so many aspects of the social world, and I kind of think that is a powerful element within a special issue. And what we're doing in this is beginning to shift the balance of research, to shift the balance of power. So MQ Transforming Mental Health in 2019 published this kind of really interesting document in which they kind of looked at funding for research in mental health and, you know, what kind of research it is. And basically, when you look at the chart, it's kind of very hard to extract from it which elements are social in their orientation. But what is really clear is that the large majority of mental health research is kind of focusing on neuroscience, is kind of focusing on the function of pharmaceuticals, and the kind of social element within it is just quite small compared to the rest. And what we know is that the bigger the body of evidence, the more we come to believe that this is telling us the truth. And there is a reality that some of the knowledge that could inform the way in which we operate is not captured in academic journals, is not funded in that way. And therefore, the place of social in the context isn't kind of giving us good voice. So partly what we're doing is kind of muscling into the space that is dense with other kinds of research. So as I draw to a conclusion, as I said before, this publication for me is like an act of resistance. It's beginning to take us into that place of radical imagination, a process where we are beginning to imagine a world that is probably beyond the reach of many, unless they're engaged in this. Radical imagination is a collective process whereby we try to see the world in a different way, outside of the borders and the constructs that we use and inhabit every day, to just imagine equity and justice for everyone. And sometimes that means deconstructing some of the systems of power that exist. You kind of go to the Galton Lecture Theatre that is no longer called that, and it took the uprisings in 2020 following the murder of George Floyd to really push to the fore what many activists and academics and others have been saying. Actually, Galton's name is highly problematic and probably should not be over a lecture theatre. Anyway, much more where you've got diverse people who will feel distinctly injured by some of that work. And it took a radical imagination for people to get together to ask for things. And there are many things, just to kind of name, for example, I'm not someone who's an abolitionist, but for those folk who might say, yeah, we kind of need to help them about defunding the police, just as an example. That sounds way out and super radical. But then of course, after the recent reports and some of the things that we've seen happening in the police, there are voices in the mainstream who are now saying we probably need to kind of have some incentivization, which means that the police don't receive their funding unless they begin to implement some of the recommendations from Louis Case's report, which is in a version, that very thing that sounds way out and radical. This publication is about activism, citation activism. It's about resistance to dominant theories. It's activism in terms of embracing plurality and multiplicity in a way that we don't often see. The co-production of it with people from diverse backgrounds and indigenous voices, from feminist perspectives, bringing in decolonizing perspectives. And it's about a collective process. So, sometimes we think that we've got these two separate perspectives. You've got, like, medical, and then you've got the social in terms of our orientation. It's like oil and water, they don't mix. But of course, if we agitate enough, we can emulsify, we can kind of get something different. And that's what this special issue does. And I leave the last words to someone whose work I really value, Dr. Jessica Hernandez, who identifies as an indigenous scientist. Despite Western education and the sciences continuing to try and put me in boxes, my worldwide views are interdisciplinary. And I think that that's what we see. And that's what I ask us all to embrace, is that possibility of multiplicity. Thank you so much.
Thank you so much, Harry. That was fantastic opening words. I would now like to invite the panelists perhaps to join us in front at the table. And we will start with a contribution of our Lived Experience Advisory Board. Roger Griffiths wanted to join us today in person, but instead we recorded his presentation earlier today. We will start with that clip quickly and then after ask the hands.
Raza, wonderful to see you. Thank you so much for joining us remotely today. And I'm going to hand it over to you to present the points that you and the LEAP have developed together.
Thank you, Dorota. So it's lovely to be here. Thank you for inviting me. Unfortunately, I've not been very well, so that's why I'm not there in person. But I'm a member of the Lived Experience Advisory Group, and which is part of the Centre for Society and Mental Health. And we had a discussion recently on what could improve research. So I'm going to summarize some of what we discussed. Thank you, Dorota.
Thank you so much. I will share your slides now. Here's your first point.
Yeah, so the first thing really to think about is the power dynamics. And I think without thinking about power dynamics and shifting the power more towards service users, I think people with lived experience, I think we need to really do that. So I think it's fair to say that we often feel that there are people have power over us, whether that's NHS, government, or academia, and we need to think about shifting that. And I think organizations need to be willing to have a look at that and make some changes in the way they work. And it's not just about generating more and more research. I mean, I know that's a focus of academic institutions, but it's also about, what impact do we make as a result of that? And we need to think about, well, who is listening to it? Does it reach people in the corridors of power who have the capacity to make changes? I think often what happens is that politicians, with their a priori ideas and ideologies, they're very keen on the research that backs up their existing positions. But if something challenges that, they tend to let it gather dust. So I think when that happens, I think you should use your platform to critique government policies when you know that they're creating conditions, to make people ill, as they have been doing for quite a long time. Next. And it's not just about involving service users in research. I mean, that's very important. How can that be? How can the power dynamics within research be shifted? But it's also about, looking at research as being part of this nexus of, funding, agenda setting, research, and then implementation and policy making. It's not just the research aspect that we need to look at. And I think it's fair to say that in some of these other processes, there isn't much involvement work going on, actually. Next, please. It's important to kind of look at the ecology of groups in mental health, because I think what often happens is you have these big names like Mind, which often kind of spread their leaves and overshadow everything else, and some of the small grassroots community organizations don't continue, and I think that's a pity. That's a pity. They obviously know how to work the corridors of power, these bigger organizations, but I think what they sometimes lack is that being rooted in particular communities and really understanding local communities very well. So next, please. Yeah. And I think to really show that you value lived experience, people need to be paid, properly paid. That's how we kind of recognize, value people in our society we live in. But also you need to ensure that people who are involved have some kind of support network. And, it could consist of developing their skills, their research skills. It could consist of having safe spaces to talk about when, things happen that are particularly triggering. But without that support network there, I think people can be put off from actually participating. And then finally, I think you need an infrastructure whereby the learning from these initiatives isn't just lost, when the 3-year or 5-year funding comes to an end, as it often does, because what then happens is that it's just like fireworks, they kind of illuminate the sky for a few seconds and then it's lost, and 10 years later someone's forgotten about all those findings, and then they have to recreate the wheel. So we need to have that infrastructure to hold the learning. And could we have the final slide, please? Thank you, Duerta. So I think this speaks for itself, really. But basically, we need to have more gardens, and we need to have more greenhouses. So I've come to the end there. Thank you.
Great. Thank you so much. I'm going to stop.
Our next panelist sharing reflections on this issue is Stephanie Hatch. And I wonder if all the panelists would like to come to the front, actually, and we wanted to make it a bit more of a conversation. That's why we also said not to use slides from here on. This will be the end of the PowerPoint slideshow. So please, everyone, and circulate. You keep, yeah, I know you always.
Gotcha.
Thank you.
Hi, everyone. I'm Stephanie Hatch. I'm a professor of sociology and epidemiology. I'm a co-lead of the Marginalized Communities program within the Center for Society and Mental Health. And I also lead the Health Inequalities Research Group and co-lead the Health and Social Equity Collective at the Institute of Psychiatry, Psychology, and Neuroscience. So my focus on social theory is on social interaction between groups, structures, and systems, tackling social problems concerned with social identities, equity, and justice, with an emphasis on social relationships built across systems and institutions, so academic, health services, community organizations. And conceptualization of the social in my work focuses on how the social is dynamically formed and contextually dependent, so geographically and historically. And it's the social in the interactions that I'm really interested in, the experiences, the practices, and the behaviors that are shaped by and are shaping our individual social statuses and identities, as well as structural factors that are agreed upon and formed by groups and communities and within institutions. For me, the social is a process, and it's a reciprocal relationship between people, groups, and social institutions. I'm interested in how social theory seeks to explain how these systems and structures persist. So going back to my time as a PhD student in sociology of mental health, I've had a very complicated relationship with social theory. I find it both fascinating and part of the problem. The problem I have with social theory is who's generating social theory. For too long, social theory has been the product of the most advantaged with the most power. Those who, despite their sometimes radical views, had a hand in maintaining oppressive systems and structures, ultimately using words to exclude people and people most affected by the systems of oppression, creating social problems that unnecessarily expose many of us to adversity right over the life course. However, I was fortunate as a PhD student to be taught and mentored by Black feminist scholars, theorists who helped me to not be silenced and to ultimately be silenced by those ultimately benefiting from these systems of oppression that are in place. So I am grateful to this special issue that took on these challenges to make theory more inclusive and more accessible. In this special issue, there were many important considerations and challenges, and parts that I found challenging, because some of the suggestions are, of course, easier said than done. For example, Bema and colleagues, as well as Hassan and others, pointed out some of the often unspoken difficulties of doing better. These difficulties can be sometimes overwhelming. But then I think about how much work actually goes into maintaining structures and systems of oppression. And that motivates me to know that at the very least, we must match, if not surpass, that energy to do better. The authors emphasize the need to respect and amplify existing and new knowledge production and evidence being generated among those with lived experience and with communities most affected. As discussed in several of the articles, inclusion has to be a practice. Who's involved in knowledge production? Whose frame of reference is dominating public discourses? Whose lived experience are we focusing on? Where is the community voice represented? Now, at this point in my career, I spend most of my time talking to people outside of academia, people across systems and across sectors who not only want to better understand the social problems, but importantly, want to take action, want to enact sustainable change. And first and foremost, they need access to the evidence. And social theory is an important part of that evidence. As you know, language is a tool of power. The accessibility of theory is dependent on social theorists considering how the theory is communicated, to understand the power of the words and how those words are often exclusionary. One of the many things I admired about my PhD supervisor, Len Perlin, who's a theorist, was his ability to write and communicate his stress process theory and how he applied it to mental health research over the life course and his focus on caregiving, using the kind of language that did not exclude the most affected or exclude those who are deeply engaged in sociology. So to progress, we need to work differently. And to work differently, we need to think differently. and be much more creative, striving to use inclusive and accessible language to communicate and share across disciplines and across sectors. Alongside making space for missing voices in social theory, this has to be the part of the practice of inclusion. Thank you.
I'm David Moss. I'm from SOAS down the road, and I'm a professor of anthropology there. And in a short while, I'll be heading a new Centre for Anthropology and Mental Health. There's so much that could be commented on in this really rich gathering of papers. So many aspects of the social causes, of networks, network effects, social categories and their effects that call out for comment. And Doctor's invited the panelists here to comment on what difference theories of the social make for mental health research in action and action. And I want to sort of reverse the question and ask, what difference does engagement in mental health practice make for social theorists? I'll put it the other way around. And the question comes from my reflection on this fantastic collection from my current position of immersion in ethnographic field work in a mental health care setting. And more on that in a minute. I want to comment on, first, how the social presents itself in mental health care. Second, on caregiving as social inquiry. And thirdly, on the consequent co-construction of the social in those contexts. Now, perhaps for others too, working in mental health care, we encounter the structural as well as the individual, because we encounter the structural socialized into individual bodies and subjectivities and dispositions and relationships and suffering. And a lesson that we can take from the sociology of Pierre Bourdieu about the idea of habitus, that the social structural is in our bodies, in our being. Or we witness in Hacking's looping effects, as people's experience and behavior are molded by the identity and diagnostic categories that in turn adapt to the lives in relation to which they orchestrate care or the lack of care. But working in mental health, mental health also constantly reminds us that the physical world has a reflexive and a self-aware property. People may be made up, in Hacking's terms, by category labels, but they're also refusing, tactically engaging with, evading, resisting, as well as deploying these classifications. Then, as Dominique and others in that wonderful paper skillfully show in Brazil, psychotherapy may itself be a route to enhanced reflective awareness of the social, especially as the source of emotional damage, and thence a motivation for political engagement. And this brings me the thought that caregiving may equally be a means to social insight. In their book, A Passion for Society, How We Think About Human Suffering, Ian Wilkinson and Arthur Kleinman aim to return caregiving to its position as a locus for social understanding, getting at, as they put it, getting at what holds social worlds together at the level of moral experience. They call into question the historical separation of social inquiry and social care. That was the foundation for anthropology's claim to be a science of society, to separate itself from care and responsibility, to be the science. The question I'm interested in is care as a form of social inquiry, and the theories of the social that therapeutic practice itself might engender. And I mention that because for the first 5 years or so, I've been in mental health care practice, in particular being a practitioner of open dialogue, an approach within an NHS community mental health team, and using this as the means as well as the object of inquiry. 1 minute, help. Open dialogue, narrative, and other forms of therapy are a means for collaborative exploration of the social, of the relational, of meaning. But this also expects a different orientation to categories, to concepts, and to observations. The stance of the therapist is also the stance of the research, which borrows from the theorist Mikhail Bakhtin's idea of the unfinalizability of the person or the situation, never fully enclosed in categories and objective and abstractions. So the point I'm going to have to skip what I was mostly going to say. I'm afraid. But I think that a couple of things to emphasize. One is the inherently relational nature of social research. We come to knowledge through social relations. And in fact, in that wonderful article that was also mentioned just now, we also know that our data is made through relations, but can also be unmade through relations. If relations of research break down, our data can disappear and dissolve. But I wanted to finally say that in consequence of the relational way in which we work as ethnographers, but maybe in other social sciences as well, there is a contingent nature of the theory of the social, our experience of the social. As ethnographic researchers, we have to abandon certainty about what the social is, and instead participate in its construction along with those, or its assemblage, along with those we are trying to collaboratively understand. We don't so much collect data about society or culture for that matter, but we experience contingent events like everybody else and try to make sense of them. Social science, in this sense, has an experimental quality, as the anthropologist Tim Ingold points out, and Kirsten Harstrup is another theorist who brings this perspective, just coming to it. So it has an experimental quality as our experience and our attention is educated by those we research alongside. So the call then is for recognition of this relational, of this contingent nature of the social as we explore it in methodologies which are necessarily relational, and that important lessons for how to do social research, how to understand, how to engage with and change the relationship between researchers and research can be gained from therapeutic practice as well as from the social sciences. And I'll end. Thank you.
Very much. My name is Sridhar Deparum. I work at King's College London and the King's Global Health Institute. So I was told a long time ago, never ask questions you don't want answers to. I don't know why I'm here, so I don't, esteemed panel. So I'm going to talk very quickly about something very simple, which is what does the social mean to me in this particular context? So I work in the area of theories of social justice and health. And the idea is that, when a lot of people have been mentioning the idea of justice, inequity, inequalities, equity, rights, etc. And so what I have always been interested in is what exactly do you mean by all of that? So when you poke people, when they say health equity, for example, in America, what people are actually saying is racial equity in health outcomes. In other places, they mean very different things. Or everyone says, oh, I do equity. And it's like, well, what kind of equity are you doing? What does it actually mean? So why this is important is that for a lot of people who work and have been working on health and justice, often go to the language of rights. Someone is sick, and therefore they should have a right to the access to medications or treatment or et cetera. Someone is not treated well, so they've been discriminated against, et cetera. What I began there, in the sense that I do think that we should have rights in relation to health, but I'm not interested in just right to health care, for example. I'm actually interested in the right to health. And that opens up a much bigger conversation about what is health, but also how is health created. And that's really where sort of this idea of the social comes in, which is that our health, our ability to have control over our body behavior is not just individual, it actually will be, sort of is situated in the community, the country that we live in. And so the social is profoundly important in the sense that this is what causes the determinants and distribution of health and well-being of human beings, individually and communities. But aside from being a description, what we need to do is, well, what kind of society do we want? And that's where the political philosophy comes in, which is about what kind of social justice do we want? And that, I think, these articles kind of touch on, but it's this idea that there is a difference between what is and what ought to be. And a lot of social science researchers really don't want to make that distinction, because it's really what they want to do is, I've seen this and I'm describing this, and therefore we should do this. And I think that this is the one big thing that I would encourage all of you to do, is that there is actually a really big difference between describing the world and making an argument for a better world. And we really do need to think much more about what social justice means and what kind of theory of social justice we want, and what kind of issues around health and health inequalities we want. So I'll end with sort of some polemical statements. One is that social injustice is bad for health. Yeah. And that seems to be a very bland statement in this room, that for a lot of people, they'll say, what are you talking about? It's about what they do, it's about what they don't do, it's about whether they have access to healthcare. And what we want is a conversation that says, actually, social injustice is what's causing the distribution of ill health among certain kinds of people, certain kinds of communities. And what we want to do is talk about what those bad determinants are. But we also have a really, really neglected area, which is what causes good health and well-being in human beings, and what should we do about identifying those, and how do we make sure that people have those as well. So we can be focused on disease and impairments because these are sites of human suffering, and we want to understand why it's happening and what can we do to stop it. But we also, it's not just simply, as someone said, we're not trying to reverse the tractor that's run over people. What we want is we actually want to find the causes of health and disease. The second political or polemical statement is global injustice is bad for most people on this planet, right? And so health and well-being for most people on this planet is bad because of the global architecture and the conditions and the systems, and that is actually benefiting very few people in very few countries. And so if we want to think about the social, I encourage you, not only encourage you, I will come after you if you keep talking about it as a national problem. Yeah? This is not a national problem, which is that health is not created nationally. And what we do here doesn't just stay here, it's actually impacting the health of people. So the articles, so. But I think that they're getting there. But I really want to make these 2 points, is that you really need to focus on social justice as the problem. And we really need to start thinking about global injustice. Thanks.
Our next speaker will join online and through the books, which is over here.
Am I supposed to be online now? Okay. All right. By asking us to draw on our own work to fathom the difference that theories of the social make for mental health research and action, Dörte and Dominique, and in fact, everyone who has spoken so far, has given a task that is both sobering and inspiring. When I say sobering, it's because it it requires a reflection for someone like me who has spent many decades of research. I'm trained as an anthropologist, but also trained in epidemiology as a way of learning another language and being able to code switch, being able to figure out how to bring diverse voices within epidemiological thinking. But anyway, sobering because as I look back on my research, frankly, I realized that there are real world limits to what I thought were practical perspectives on the social. And so sobering also, because unlike praxeological research, which is discussed in a couple of the papers in the special issue, and unlike action research, the work I've done and my collaborators, and many of those are people with lived experience, seems to have an effect in very small, modest ways, and in ways that really defy systemization. And I will give an example in a minute, but one of the most striking examples of that is an early ethnography that I collaborated on in the Bronx in New York on probably, well, one of the first user-run, as they called themselves back then, user-run alternative to sheltered workshops, to supported work, and so forth. These were people with lived experience who were hospitalized. Most of them had been homeless, and they were able to negotiate with the administration with the help of some of the professionals that worked in their unit to negotiate to transfer the money that was being used to finance their supported work and so forth into their project, which was to start a drop-in center and a mobile soup kitchen for other people. We conducted an ethnography of the study, and it was discussed with the users and so forth. But in the end, the mental health professionals, administrators at every level had much difficulty to accept the idea of the social that these users, as they call themselves, were practicing and developing within the drop-in center. In other words, rather than the social being a larger community of other people in the same situation as them, they opened up the drop-in center to everyone in the neighborhood. And they also refused, because it was very difficult for them, they refused a lot of the additional programs, attached programs that were being offered to them, such as to live in a new special supported housing unit, because, as they put it very clearly, they were tired of living with people like themselves in close contact, exposing themselves, their most private aspects of their lives to one another. They wanted another kind of living. They didn't have communities to go back to, but they wanted to find more mixed communities. The model for me of that is the Italian model in Trieste of social cooperatives, which bring together not only people with lived experience, but people who are unemployed, people from many walks of life, and work and build together. But the point of this is that two notions of what a social group should be, of what a social network should be, of what the social is, clashed. That of the people with lived experience and that of very open-minded mental health workers who could not understand it, who feared what it meant to truly experiment and open up to another kind of community. People really coming off from the street, single mothers, runaway kids, and so forth. The second point I would like to make about relationality and what I've learned from my work, and as you can see, I'm putting it into dialogue with the issues and some of what has been said before, is that as an anthropologist, I am always looking at process. I'm always looking at actors involved in processes, and through their social ties, because relationality is central to life, through their social ties, it is always possible to work back to the communities, the organizations, the institutions, the governmental forms that mutually or sometimes in a conflictual way shape their own actions. Just as an example, intersectionality in this case doesn't necessarily have to be imposed because it emerges from looking at how people live. Most recently, I have shifted to what I call ethnography beyond the clinic, beyond mental health centers, into the ethnography of mental health in communities and different social worlds. In other words, looking at the ordinary, everyday life of people living with severe mental health problems. And I'd like to just bring as a last example my a recent research in Senegal, where we, my Senegalese colleague and I contacted people with experience, not through clinics, not through mental health programs, and there were no groups of people with lived experience, no associations, advocacy groups, and so forth, but rather through neighborhood leaders, through residents, through community leaders, and so forth, who were automatically affected by people dealing with very severe mental distress. And this way, we were able to focus on their social worlds and relationality rather than the notion of a social world that might come out of official patienthood. From observations of everyday life, both in and out of crises, we developed the idea of thick therapeutics being the social, symbolic, and economic embedding of mental health crises and of the ensuing disturbances that mental health crises cause in local and kin moral economies and in therapeutic quests. So we discovered how for example, the idea of who has authority to speak for whom had been transformed in a gendered sense, which I can't get into right here, but truly in a gendered sense, but also had because of larger economic transformations, and this also deresponsibilized people who earlier had provided for their community members in distress. But the immersion in social worlds reconfigured for us the construct of mental health itself, because this is not the way people saw these forms of social distress.
I think you have to come to an end because we have still a program to
Okay.
go through.
I'm sorry. Are you asking me to wrap up, right? Yeah, I'm very sorry. I am a very slow speaker because of my own current health issues. But anyway, what I wanted to say is that we discovered forms of solidarity which are forms of solidarity that were totally unexpected. For example, new figures of care, such as anonymous street merchants, better off neighbors, strangers from the contemporary African diasporas, who provide for people with severe problems when their families cannot or will not. And also the solidarity inherent to religious charity. And Hari talked about it in another way, the sociology of religion he grew up and how that affected him. But also forms of charity linked to political parties, unions, and
And we would like keep a
Okay,
bit of
I'm
time
sorry.
for the Q&A. I'm so sorry to cut you
Okay.
short.
What I want
Just
to,
wanna make sure.
just to end, my point is that from that, we attempt to build, we're trying to build a community-based participatory mental health, but not through importing models, but working from the ground up. And I can talk about how we're doing that but, at another point. So sorry to have run over, really.
Yes, I want to use at least the next 10-15 minutes for Q&A.